एक्चुअली हमें बचपन में सिखाया गया था कि कभी भी लोगों से मिलो तो मॉर्निंग ही कहते हैं। हाँ, तो ये मॉर्निंग भी है, इवनिंग भी है। Respected seniors and dear friends, I am proud and privileged to be part of this CME today. We have our regular morning CME every 15 days. For that I really feel great. We have talked on different topics, have delicious breakfast and grand get together. आज मॉर्निंग की जगह हम लोग इवनिंग में जीपी एसोसिएशन की मीटिंग कर रहे हैं और इवनिंग में आके अच्छा लग रहा है, आप लोगों को भी अच्छा लग रहा होगा। I invite our president sir Dr. Agrawal to come forward and sit on the dais. Please clap your hands together. Now I request our guest speaker, Dr. Sanjay Verma, to please come on the dash. Welcome because he has come all the way from Delhi to deliver his talk on management of colon cancer. Thank you, sir. Now I invite Dr. Upma Jaiswal to please come on the dash. She is the second speaker of today's CME.
Everybody clap your hands.
Request Dr. Agrawal sir to honor our second guest speaker, Dr. Upma.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय
होती है मुझ पर रोज, होती है मुझ पर रोज तेरे रहमतों के रंगों की बारिश, होती है मुझ पर रोज तेरी रहमतों के रंगों की बारिश। मैं कैसे कह दूं मेरे मालिक, होली साल में एक बार आती है। थैंक यू। और नेल्सन मंडेला ने कहा था, ये बड़ा फेमस कोट है, एजुकेशन इज दैट मोस्ट पावरफुल वेपन विच यू कैन यूज टू चेंज द वर्ल्ड। जॉन डेविन के शब्दों में, एजुकेशन इज नॉट प्रिपरेशन फॉर लाइफ, एजुकेशन इज लाइफ itself. Now I invite our guest speaker, Dr. Sanjay Verma, for his talk on management of cancer.
His area of practices and expertise include all advanced laparoscopic complex GI surgeries and bariatric surgeries. Dr. Sanjay Verma has completed fellowship in bariatric, colorectal and hepatobiliary surgery. I welcome Dr. Sanjay.
Thank you, sir. Thanks for my introduction. As we all know, colon cancer is the fourth most deadly cancer in the world. The incidence and mortality of colorectal cancer is rapidly increasing in all the countries except few developed countries. If we talk about the risk factor for the colon cancers, so there are various hereditary factors. The hereditary colorectal cancer syndrome, which consists of the FAP familial adenomatous polyposis. Another one is a Lynch syndrome, which are the basically inherit and has the potential of malignancy. Another one is positive family history. The colon cancer is more common in the families, in the patients who are having the positive family history. Apart from this, inflammatory bowel disease like ulcerative colitis, Crohn's disease, these are the various predisposing conditions. It is the, if we say the menopausal therapy for the female, statin therapy, ethnicity, male genders are more prone for the colon cancers. There are the modifiable risk factors which increases the chances of colon cancer, like smoking, proceed meat intake, alcohol intake, red meat more consumption, no intake of vegetable and fruits, more of a less of the fiber diet, more of the fat diet, and we can always say that obesity also is a risk factor for the colon cancer. There are few modifiable risk factors which can reduce the risk of the cancer. We should be more active, we should be doing our physical activities very regularly. The diet should be consisting of a whole grain. Dietary fibers should be more in our diet. Fish intake decreases the risk. Vitamin C and B components helps in reducing the chances of cancer, and calcium supplements. If we talk about the signs and symptoms of colon cancer, so we always see the patients who are coming to us having the most specific complaint of rectal bleeding. The bleeding may be because it may be red in color, maybe altered blood. Another complaint the patient brings us to is that complaint of tenesmus. Tenesmus means patient goes through past emotions many times. Maybe the bowel evacuation is not complete. Another symptom which is continuous, constant and diarrhea. This may be because of any of the obstructing lesion to the colon, which causes the constipation at one time. When it is being given the way, it may lead to the diarrhea. Another one is inadequate, we can say the unexplained weight loss. There may be a possibility of the patient may be having fatigue and maybe feeling like weakness without of any specified symptoms. This is the anatomy of colon cancer. This is the anatomy of our colon, starting from cecum, ascending colon, this is the transverse colon, descending colon, sigmoid, rectum, and anal canal. So, once the diagnosis has been made for the colon cancer, then there are the treatment options which is available. Primarily, it is like the surgical resection. After that, if it is required, chemotherapy. So there are a few surgical principles which has to be followed very genuinely in surgery of the colon, in the surgery of a cancer. It may be colon, rectal, or maybe a sigmoid colon. The adequate resection of the margin is must. There should be the margin which has to be resected should be tumor-free, should be negative on both sides, and adequate nodal clearance. That means there should be the resection consisting containing of the mesorectum with the adequate lymph nodes. Without that, our surgical clearance is inadequate. If this figure shows basically the standard resection for the right side of colon and the transverse colon and mid of the transverse colon. In right hemicolectomy, if the tumor is present over the cecum, then right hemicolectomy is indicated, and the resection site should be till the right branch of the middle colon. If the tumor is more proximal to the transverse colon, then extended hemicolectomy should be done. where the both branches, including the right and left branches of middle colon is to be resected. Another figure which is showing is the growth within the transverse colon, and the resection should be done over there, considering the 5 cm of the length, proximal and distal to the tumor site. This is the standard figure showing the resection if the cancer is on the left side, which is called as the left hemicolectomy. Sigmoid colon and rectal growth, as the dotted spots show, that should be the resection level. What are the oncological principles which needs to be followed during the surgical clearance? That means the margin of the colon, first one is the CME, that is the complete mesocolon excision. The mesocolon consisting of the lymph node should be excised. Another one is CVL, central vascular ligation. That means the branch supplying that area, that portion of the root should go till the root and excision should be done. Another important thing to be taken care in the mind is D3 level, where the lymph node has to be excised till the root of the supplying vessel along with the ligation of the supplying vessel, so that there should not be any remnant of the lymph node, so that the chances of recurrences are lesser. This figure is showing the holy plane where from which the resection should be start. This is the TME basically. This is the figure showing the various stations of the lymph node. The red mark pointed are pericolic lymph nodes. Another one is in blue, which is the principal lymph nodes. And yellow colored, this is the lymph node which is in the center. And white color are the paracentral lymph nodes. Whenever we are doing the resections, hemicolectomy, right hemicolectomy, left hemicolectomy, this point should be taken care in the mind, that it has to be completely resected. As much as possible, no lymph node should remain. This is the D3 resection which I am talking about. The lymph node should be reached to the base of the arterial and vein, and excision should be done after ligating the main vessels. Once the resection is done, now comes to the point of adjuvant chemotherapy and the survival rate. If the growth is in stage 1, that means it is confined to the lumen submucosa of the colon, where there is no lymph node involvement and there is no metastatic involvement, and 5-year survival of that patient is roughly around 85 to 95,000. In that condition, adjuvant chemotherapy is not required in fact. Second stage, where the growth is still confined in the lumen, it is in the muscularis mucosa, and lymph nodes are negative. There is no metastasis. In that condition, according to the stage of a high risk and low risk, in low risk patient, if the patient is not having too much of a comorbidities and all, and lymph nodes are negative, the 5-year survival is roughly 80 to 85%. No adjuvant chemotherapy is required in that patients. In stage 2, where there are the high risk comorbidities are there, survival rate is also 80%. In that condition, we can consider for adjuvant chemotherapy, that as either if we can take the combination of 5-FU-LV or Foloflux or Xelox. In stage 3, the 5-year survival rate, as shown in the figure, is roughly 60%. In that condition, chemotherapy is required, and definitely we should go as per the standard norm of chemotherapies. As I have told you in my previous table, that stage 1, when it is T1 and T2, primary surgery is done, no chemotherapy, no adjuvant is required. T3, T4, stage 1, there is primarily the growth resection is required, no chemotherapy, adjuvant is required. Stage 2, when there is a T3, T4 involvement, definitely there will be a role of adjuvant therapy. In stage 3, when lymph nodes are positive, we definitely do the resection and after the resection, we can go for the chemotherapy also. The high risk patients are high risk is that when the chemotherapy is required, when the lymph node sampling is done of minimum 12 lymph nodes, depending upon the positivity of them, poorly differentiated carcinomas, where there is involvement of vascular, lymphatic and perineal invasion, and the obstructive region containing the reaching up to the serosa, or there may be a perforation of the colon that definitely would require the adjuvant, and stage 4 cancer. Now, this is basically what I was talking about till now was the routine plan which we were doing since very long years. I want to show you, I want to discuss you with what is the new management nowadays, including the previous one, is normally occult blood is tested for positivity of colon cancer whenever there is a occult blood in the blood in the fetus. Then we can consider the patient might be having some growth, maybe in the ascending colon also. Nowadays there is another screening which is called as FIT. FIT means fetal immunochemical test. If this is the immunochemical test, the sensitivity of the colorectal cancer is almost 97%. At the level of detection of 2 microgram of hemoglobin. If FIT is positive, that means the patient is definitely having the carcinoma, and if the FIT is negative, that means in 99.8% patient may not be having the carcinoma. Apart from the routine investigations like colon cancer, colonoscopy, routine blood test, CT, and PET scanning. Nowadays, the screening for colon cancer, FIT is also used for the screening. The role of neoadjuvant chemotherapy in colon cancer is like nowadays 6 weeks before a surgery, neoadjuvant is given that reduces the size of the growth as well as make the surgery more easy, and the outcome of the surgery and the results are much better. Recently, there is the trend of endoscopic treatment for the localized tumors less than 30 millimeters. The endoscopic mucosal resection (EMR) and endoscopic submucosal resection (ESD) are the two methods of removal of the pre-malignant and early malignant lesions. ESDs basically refer to the lesion which is limited to submucosal invasion and the lesion is less than 30 mm. ESD is done, endoscopic submucosal resection is done for achieving histopathological evaluation of the special margin, enhancing its utility and avoiding the further unnecessary intervention. So these are the two endoscopic procedures which has been more widely used nowadays for the small pre-malignant conditions or the tumor which is less than 30 millimeters and it is confined to the colon area only. The oncological advancement, as I told before, that CME, basically the complete submucosal resection, and TME like submucosal resection. There is another blending CME with CVL is a logical step to ensure the best locoregional control. If we go to the base of the vessel, ligate the vessel, and take out the lymph node along with the tissue, ensures us that maximum of the lymph nodes are being taken out. That improves the outcome of the surgery and the chances for the post-surgical chemotherapy and another new adjuvant also reduced. Now, as we know, there is the advancement in the surgical technique. If we consider in 90s, broken surgery was very common. In late 90s, it was laparoscopic surgeries. Nowadays, it is a robotic surgery, which is being common trend for the surgical procedures, and these are the normal surgical procedure which has been done. Minimally invasive procedures now done laparoscopically and robotically also. In laparoscopy, there are 3-4 small holes are done, through which all complete mobilization of the colon is done, complete mobilization of the lymph node is done, and the resection point is decided as per the growth. Normally, the 5 cm beyond the growth and 5 cm proximal to the growth is the area where we resect, and end-to-end anastomosis is done with the staplers, which are very more common. The life is more convenient with the use of staplers nowadays, and the outcome of the surgery, chances of leaks and all, is also reduced by using the staplers. As with another like all other laparoscopic surgeries, the advantages are small incision, less post-operative pain, short hospitalization, improved quality of life. These are the advantages of laparoscopic surgery. Robotic colectomy is very common nowadays. Maximum, if I talk about Delhi, almost in every big hospital there is a setup for the robot. And the robotic colectomy has been compared to the laparoscopic approach, mostly with the coherent studies. In general, the robotic approaches appears to result in the longer duration of time. It's more costly and it's a little bit expensive. The outcome, the results, I feel is same as laparoscopy and robotic surgery. So that doesn't make any difference between the laparoscopic surgery as well as a robotic surgery. The advantage only in the robotic surgery is that tremor filtration, if the age factor depends upon if there is a tremors in the hands and all, that is overcome with the robotic surgery. Apart from this, there is a 360-degree rotation of the arm, so that the deep cavity, if you want to work in the deep cavity, it is more beneficial and very much effective. Apart from this, the ergonomics supports for the robotic surgery. For advanced cancers, which are like growth is at the submucosal and mucosal level, perforated growth, and we can say if the growth is very extensive, long, if given the way to the colon, perforation is open, I would still suggest open technique is the best one. With development of laparoscopes and endoscopes, now there is a multifunctioning ICG technique which is used as a navigation, through which endosilin green dye has been injected, and this dye basically determines the level of the growth, determines the level of the lymph nodes which are being involved, and the resection is more easily done as this figure is showing. Normal colon without ICG, and another one is basically induced with ICG, and it's a green area which is the extent of the growth, and it's very easy for the mapping of the surgeon to go till that area and resect the thing, so that the resection is good, resection you can do much better, and the outcome of the surgery is improved by the use of ISC. There is another one, is the targeted therapy for various like advanced cancers, where we need to target a specific gene and the proteins which are responsible for the carcinoma, and for the colon carcinoma it is more commonly used nowadays. Immunotherapy for colon cancer, colorectal cancers, which is also a newer concept which has been tried in various stages of the cancer. Thank you.
Thank you, Chairpersons, Dr. Agrawal ma'am and Dr. Pratibha ma'am. And thank you, Dr. Pratibha Gupta ma'am, for showing confidence in me and inviting me here. Respected teachers, seniors, and my dear friends, the topic of my presentation today is Intrahepatic Cholestasis of pregnancy. So this is a very dreaded topic, as ma'am said rightly, and you all are very scared as soon as you hear the word jaundice or you see increase in bilirubin or hyperuremia in a patient of pregnancy. And we have to have a few background knowledge for this, because intrahepatic cholestasis of pregnancy, it defines cholestasis, which means stasis of the bile. The solid is bile, and when this one happens, it is a reversible type of hormonally influenced cholestasis. And the most common pregnancy-related liver disorder, and it's characterized by generalized itching, which often starts from the as pruritus from the palms of the hands and soles of the feet, and there is no other skin manifestation is there, like increased cholesterol, which manifests as Amma, or hyperuremia signs are there, or jaundice is also not there generally. Except for the scratch marks which are there on the skin. It frequently develops in the late pregnancy, and especially in females who are genetically predisposed. And most often it presents in the late second or early third trimester of pregnancy. What happens generally, it affects very less patients in the USA by 0.1 to 0.2%, but in overall the pregnant obstetric population, we see 0.2 to 2% of the cases, and there is no defined clear etiology of it. It is mostly multifactorial disorders, and it can be attributed to genetic, hormonal, or even environmental factors. And the diagnosis is mostly a diagnosis of exclusion, and the lab findings which have come across, examination reveals nothing but scratch marks and pregnancy over the skin marks. And the pathophysiology leads to, for that we have to go into slight details of the metabolism of bile. Bile is mostly 70% is bile acid, and then there is bilirubin in it, and phospholipids are there, electrolytes are there, water, and even xenovitamins are seen in bile. And what happens if bile is formed from, primary bile acids are formed from cholesterol in the liver, and especially the endoplasmic reticulum, and there they are, the rate limiting enzyme is 7-alpha hydroxylase, which breaks down the cholesterol into cholic acid and deoxycholic acid, and then they are conjugated with taurine and glycine into deoxycholic acid and glycodeoxycholic acid, and then cholic acid turns into glycocholic acid and taurocholic acid. And from there, the story starts here. And from there, it transports into the biliary molecular system with the help of BSEP, biliary salt export pump. So this is the biliary salt export pump, which is a BSEP. There lies the effect in these diseases. And the bile salts are not able to enter into the bile molecular and not into the enters into the duodenum further because of this it is saturated in the liver, and therefore we see that excretion of bile salts is effective in this disease and leads to increased serum bile acids. And thus the bile salts are deposited in the skin, especially taurocholates, which is responsible for intense pruritus. The cause is generally idiopathic, and we can attribute it to genetic disorders, which play a very important role in this disorder. And it's mostly seen in very high cases in South American countries and South Asian countries. And Chile is one country where it is more genetically predisposed women are there, and around 15% of the cases are seen in obstetrics. And as we have seen, the BSEP proteins is there, which plays the receptor defect is there, and also there is multi-drug resistance MDR3 protein defect is there, and this is also responsible for defective uptake of conjugated bilirubin into the bowels. So that is also not able to transport. And therefore, most of the times you have to take family history, because in the mothers, daughters and siblings, it is seen around 10 to 15%, even 18% cases are there, and the family history is there. So there is a special entity, progressive familial intrahepatic cholestasis, which plays a very important role, and we have to be very particular with the history. And also those patients which are predisposed to gallstones can develop ICP, and also seen whenever the patient gives a history of intake of oral contraceptive pills and should develop cholestasis, then we have to be aware of the particular problems, and this can happen later in pregnancy. The pathophysiology, we have seen that estrogen plays a very important role in this disease. The estrogen leads to biliary stasis, and because it causes inhibition of that pump which I told right now, it is bile salt export pump, BSEP pump, and that comes as effect and it leads to the disease. And all steroids, even progesterone metabolites, progesterone sulfates are seen, which inhibits the pump. And most of the steroids like estrogen, progesterone, corticosteroids, they have increased during pregnancy and therefore leading to cholestasis or the biliary stasis. Now the pathophysiology also the high estrogen, patients if they are exposed to high estrogen like in multiple pregnancies or even in preconception period, if we witness OHSS or ovarian hypersecretion syndrome, those patients are also predisposed to this disease and it should be there in our mind. And we should always take proper history at that time whether she has ever been exposed to high estrogen in the previous history of her and she developed cholestasis or gallstones, we should keep it in mind. The pathophysiology, the environment also plays a role. Vitamin D, we all know, plays a very important role in several diseases, and this is also one of them. With selenium deficiency is seen, which can cause ICP, and more common in the winter months is there when vitamin D is also less, and patients can develop ICP, and this can help us in regarding the diet, which you can do monitor prenatally, and also the timing for the subsequent pregnancy. We should always take that she doesn't fall pregnant during the winter, like she should not reach her third trimester in the winter month, if possible. And bile acids which are particularly elevated are propionic acid and chlorodeoxycholic acid, which I just showed you. And the bile agents are significantly decreased by UDCA, ursodeoxycholic acid, which is the main pharmacological treatment of this disease. Now, epidemiology, they have seen that familial clustering is seen, geographical variation is there, even ethnic group variations are seen. In South Asia, South America, and Scandinavia is one country. In Europe, which we have seen high cases. Now, epidemiology coming to seasonal variation seen in winters. Other advanced factors are there like advanced maternal age or personal family history with oral contraceptives, multiparity, twins when it is high, incidence is high. It is seen in usually the second and third trimester, and very rarely in the early first trimester and late first trimester is seen. It is characteristic as pruritus without rash, and it progresses starts from soles and feet and progresses to trunk and face and affect all the body parts, and especially it is worse at night. So we have to take care, we'll take the history and we'll ask if she is experiencing nocturnal pruritus. And jaundice does not occur, is not very common, but it can be seen in 70 to 75% of cases, and it develops later, around 1 to 4 weeks later, after the onset of pruritus. Also, vitamin K deficiency is seen because the fat malabsorption is there, because of decreased bile acids, secretion in the intestine, and this causes vitamin K deficiency, for which we have to be very careful, otherwise PPH can ensue. And dystoria history patient history of dystoria, and the differential diagnosis is from acute fatty liver of pregnancy. This is a severe obstetric emergency, and in this generally it is an obstetric emergency, and we have to deliver the patient and refer her to the tertiary care center, and also there should be a proper team for a fetal maternal specialist and hepatologist have to be taken into consideration to deal with these diseases. And dermatitis also, you can differ from other cases are there. And gallstones, that is a pregnancy, preeclampsia. Preeclampsia is one condition which we have to differentiate from ICP, because in this also liver enzymes are raised and it can give a confusing picture. Diagnosis, you all know that elevation of serum bile acids is a very important factor in this. And serum bile acids, it can be, according to RCOG 2021, it is said that disease can be categorized into generalized pruritus, mild, moderate and severe based on serum bile acids. If it is less than 20, 20 to 40 and 40 to 99 and more than 100 micromoles per liter, then it is categorized as severe intrahepatic cholestasis of pregnancy. And especially the history of abscess of liver disease at more than 25 weeks of gestation, you can place the diagnosis as ICP. The most specific and sensitive marker of ICP is serum bile, total serum bile acids. And if it is generally 0 to 6 micromole per liter and it is more than 10, then the diagnosis is, we can inject towards the diagnosis. Aminotransferase levels are not very increased, a mild increase is there, 10 to 25 times. Alkaline phosphatase may increase up to 4 times. The most important is folic acid and chenodeoxyfolic acid. The ratio is very high in these cases. And GGT is elevated. Like urinary GGT is an enzyme of liver, and also ALP, alkaline phosphatase. These are membrane proteins, membrane enzymes, and if it is high, that means the liver disease is severe, and you can have the genetic component is more severe, that means. Bile acids is suggested for the bile acid levels are suggested for the diagnosis as well as the management of the intrahepatic cholestasis of pregnancy. But there is no different criteria for the cutoff limit. But generally, for everyone, we have to take limit around more than 40 micromoles per liter. And if it is less than 40, the disease is not that severe. And but since it is a very difficult test and reporting time is more, it's very difficult to base our decisions only on BA levels. So, conventional is to see that even we can rely on alanine transferase levels. BA levels are very difficult and total serum bile acids. First, the diagnosis is great, and also we have to do the correlation studies very seriously for these patients, because they can add it to vitamin K deficiency, and the PT, PTP, INR is very important, as well as other total bile acids, total bilirubin and transaminases. Now, the diagnosis of maternal complications are very less in these patients. Generally, the maternal outcomes are good, but it can be devastating for the fetus. It can lead to sudden neonatal deaths, meconium aspiration syndrome, and also neonatal admission in NICU after the delivery. And also there is increased risk of spontaneous preterm birth. So the early recognition, treatment and timely delivery is the key to the management. And maternal mortality is high and intense pruritus is seen. And sometimes the pruritus is so intense that patient has developed insomnia and she is even thinking of committing suicide. In those cases, early delivery is contemplated as soon as fetal lung maturity is confirmed. So as compared to the fetal consultation, it is more concerning the disease, and stillbirth can happen even from 2 to 11% of the cases. And that generally depends upon the serum bile acid concentration. If it is less than 20, then delivery can be taken up to term around 37 weeks. But if it is more than 100, then the delivery should be contemplated as soon as we are assured of the fetal lung maturity. The Jaiswal said that bile acid concentration of 40 microliters per liter or greater shows the fetal complications of preterm delivery, meconium staining, and placental and fetal meconium staining of carotid fluid and placenta, and fetal asphyxia. Gorakhpur et al. In the study show that more than 100 micromole per liter of total bile acid is associated with increased risk of stillbirth. It is more after 36 weeks of pregnancy. So the bile acids play a very important role in the management. Then taurocolates, what happens in the fetal hypoxia and sudden IUD? The taurocolates, they cross the placenta and causes delivers into fetal compartment and causes fetal erythema and decreased contractility and causes fetal heart attack and even sudden IUD. Also there is chorionic venous constriction which can lead to acute fetal asphyxia as a postulated cause. Now to monitor these patients, fetal death rarely occurs before 36 weeks, but we have to keep it in mind. If it is more than 100, we have to deliver at 35 weeks. And the delivery generally is less than 100 or around 40 micromoles per liter, then 37 weeks of gestation delivery should be recommended. And for monitoring, we know that twice weekly stress test of CME is recommended, and weekly biophysical profile, and 15 days, every 15 days, unlike the lateral Doppler should be taken. But don't take pregnancy beyond 37 weeks. And to reduce the risk of stillbirth, non-stress test, we have these tools in our hand always, non-stress test, biophysical profiles, and like a lateral Doppler studies, we can tell us about the fetal well-being. For the treatment is we have seen that increased fetal testing and scheduled induction of patients with ICP of documentation of fetal lung maturity is very important. And if it is bile acids more than 40, more than 100 activities and less than 36 weeks, then patient has to be admitted. And continuous fetal heart rate monitoring is required and delivered when we are sure about the fetal lung maturation. And unnecessary increased mortality happens even if twice weekly antenatal testing is there, so fetal admission is a must. Now, ursodeoxycholic acid is the treatment of choice in these patients because it helps in the doses is 600 to 2000 mg. Delivery is for 50 mg per kg body weight per day, twice doses. You get 300 mg PD or 300 mg PDS. It reduces pruritus, decreases total serum bile acids, decreases alanine transaminases levels and bilirubin levels, and also improves folic acid and chenodeoxycholic acid ratio. And also allows us to reach term so that baby is not born preterm. And it has shown to be no significant maternal adverse events, and long-term sequelae of patients was followed up at 12 years of age and show no long-term sequelae. The treatment of this disease is delivery and recommended at 37 weeks as soon as fetal maturity is raised to prevent fetal mortality. Complications, you all can see that it can cause blood loss in women if there is vitamin K deficiency, and so water soluble vitamin is given because fat soluble vitamin K, which is generally available, will not act. So water soluble vitamin K is advocated these patients if PTIR is abnormal, and follow up is seen. Pruritus is generally resolved in 2 to 3 days, and serum bile acids comes to normal in 3 weeks to 4 weeks. 4 weeks, after 4 weeks, testing is again recommended. Now for contraception, these patients are advised with very low dose of, we should avoid estrogen in these patients when advising contraception. And ICD, previously it was said that it's contraindicated, but now low dose can be safely prescribed. And family, so most important is the recurrence rate is 60 to 70%. And we have to counsel the patient as this disease will recur in next pregnancy most of the times. And so baseline bile acid levels and liver enzymes levels should be repeated. And even prenatally and during pregnancy, pruritus should be closely monitored, and ursodeoxycholic acid should be initiated at the first sign, even prior to the result, we receive the lab results. Now I'll show you a few pictures of rash with pruritus. Now first, most common is heat rash, which we generally see in the patients, and generally because of the summer and the sweat and humid conditions, And treatment is very simple. You can ask her to use cotton clothes, loose clothes, sleep in cool ventilated rooms. And folliculitis is also very common, which can be confused, and it is inflammation of the hair follicles, get very itchy, and for that we can prescribe emollients or some menthol or 1% lotions, which can help. And prurigo is one condition which is present there in the skin, and it generally causes small intractable nodules are formed, and it can be caused by insect bite, allergy or atopic conditions. And the next which we see is POP. It is pruritic urticarial papules and clouds, and it generally develops over the stretch marks and the folds of the skin, and mostly seen in multiple pregnancies or twins or triplets when skin stretching is more. And the normal treatment is oral antihistaminics, skin emollients, and even steroids to prevent rashes or the itching. Last is this pemphigoid gestinalis, and this is seen in third trimester pregnancy. It is very rare, but it is autoimmune, and it resolves after delivery, and even its newborn can be affected because of it. Thank you all.
Thank you, Upma. It was a very, very informative talk and very practical also, because these are the problems we normally face. And the best part is the main key point is that we should take care of the LFT and bile salts. And if the bile salts are increased, then we have to terminate the pregnancy, as you said. This is very, very important for us.
So family history.
And family history is there, of course, but during the pregnancy we have to be very, very careful. And sometimes the serum period is normal. Then also we get the delayed LFT spike. So bile acids has got a very, very important role in the pregnancy. And thank you very much. It was a very, very important.